talk to us to our Emory group, and welcome. And please go ahead.
Well, thank you. Anytime I get an opportunity to interact with the team at Grady and Emory, it's an honor because I took my academic career started from there. So I have very fond memories and a great sense of appreciation. And thank you so much for arranging that, Danish. I'm actually going to talk today about endovascular treatment versus best medical treatment in posterior circulation strokes. So endovascular treatment, first of all, I just want to mention is that when we use the word endovascular treatment, it's not a homogeneous entity, it's really a heterogeneous entity. It really is a combination of several modalities kind of lumped in the broad umbrella of endovascular treatment with the intent to actually treat intracranial occlusion and achieve recanalization to restore flow to the ischemic region. So you have thrombectomy devices where you have an angioplasty balloon, you have aspiration catheters where the goal is actually to fragment the thrombus and achieve recanalization. You actually have thrombectomy devices with a retriever function. And the most recent one, the stent-based devices, where it's really a stent that's attached to a wire. And these stents are actually deployed within the thrombus and then essentially retrieved in expanded fashion to remove the thrombus from the intravascular compartment. And the technology has actually evolved since 2012. There have been several devices that have been approved with the specific intent to treat acute ischemic stroke. And the studies that were done actually looked at compared the stent retrievers with the coil-based retrievers. So the coil-based retriever is simply a coil attached to the distal end of the wire. And the principle was the same, that you deploy these devices into the matrix of the thrombus and then you try to retrieve it. And what was shown was the second generation or the third generation retrievers, which are stent-based retrievers, achieved almost a twofold higher rate of recanalization as compared to the original devices. And this recanalization actually had clinical consequences. So if you look at the modified Rankin scale 0 to 2, essentially a twofold higher chance of achieving a modified Rankin scale 0 to 2 at 90 days as compared to the old generation devices. And now we actually have catheters that serve the purpose of going into the matrix of the thrombus and actually placing a negative inspiration or a negative force to retrieve the thrombus from the intravascular compartment. And the data that we have so far suggests that the aspiration technique is equivalent to the stent retriever technique. So you have both options that are equivalent to each other when it comes down to recanalization and also clinical outcomes. So in 2013, the guidelines were really focused on intravenous thrombolysis from the American Heart Association, American Stroke Association, and essentially said that anybody who was candidate for intravenous recombinant tissue plasma activator should get intravenous thrombolysis, even if endovascular treatment was being contemplated, and that was the highest level of recommendation. A second highest level of recommendation really was for giving intra-arterial thrombolysis, and again in patients with middle cerebral artery occlusions who present within 6 hours of symptom onset. Now, pursuant to several randomized clinical trials, the guidelines were modified in 2015. And now endovascular treatment actually moved up. So it became a class 1 level A evidence. So it really moved up. So intravenous thrombolysis still retained a status. But endovascular treatment with a stent retriever was recommended if a patient actually had an occlusion of the internal carotid artery, the proximal middle cerebral artery. So it was limited to 2 specific occlusions, and the NIH stroke scale was 6 or greater. And with some emphasis on looking at the plain CT scan and excluding patients who had extensive early ischemic changes. And as all of you know, that aspect is one way of grading that. It actually grades the level of ischemic changes in various regions in the anterior circulation. And 10 actually means no ischemic changes, 0 means all the tissue has ischemic changes. So 6 or greater means a lot of the tissue, at least by plain CT scan, was preserved. Now, all the data at that point was really derived from trials that had been done between 6 and 8 hours after symptom onset. While it had been recognized for some time that there were patients who present after 6 hours and still can benefit from endovascular treatment, but I think the challenge was to identify those patients. So taking everybody did not make sense because a lot of those patients already had irreversible ischemic changes. So essentially, the Dawn trial tried to make the determination using CT or MR perfusion and distinguishing the patients who actually had a perfusion deficit and those who actually had an infarct. So essentially, what was a surrogate for irreversible brain damage. And as long as the or irreversible brain damage or the volume of brain damage was small, they were taken to endovascular treatment. And essentially, if you look at a modified Rankin scale 0 to 2, which means no disability up to mild disability, you had it's almost fourfold greater chance of achieving that if you got endovascular treatment. And the diffuse trial, looking at patients between 6 and 16 hours, again using a somewhat of a different criteria, but the principle is the same, and actually looking at perfusion imaging and the ratio for infarct or whatever with the volume of the infarct, and again showing similar results that you can achieve a modified Rankin scale 45% at 3 months if you get endovascular treatment, 17% if you get best medical treatment. Now, the main thing here was to notice was that the selection of patients was based on a quantitative automated assessment. So basically looking at the tissue that was salvageable, but not an individual interpretation, but actually an automated quantitative assessment. So it reduces the inter-observer variability. And then actually taking patients to endovascular treatment. So I think that was an important issue, that the selection based on a quantitative automated assessment allowed the right selection or the proper selection of patients for endovascular treatment. So the guidelines actually changed in 2018 again. And mechanical thrombectomy in patients between 6 and 16 hours who met the eligibility criteria was recommended. And mechanical thrombectomy between 6 and 24 hours was recommended in the presence of large arterial occlusion and considered reasonable. Now, it's also important to recognize that these are all patients with anterior circulation occlusion. So all these patients had either an occlusion of the middle cerebral artery or the internal carotid artery. And this is another way of looking at how our evolution, how our endovascular treatment has changed. So in 2011, everybody who was a candidate for intravenous thrombolysis got intravenous thrombolysis. And then patients who had severe neurological deficits, which, as you know, the NIH stroke scale being 0 to 42, 10 or greater is a pretty severe deficit, getting endovascular treatment. And then patients after 6 hours were also selected using a variety of criteria. So there was no agreement, there was a variety of criteria to select those patients. In 2016, the emphasis changed. Instead of using a clinical criteria, actually using image-based criteria, to using CT angiogram to demonstrate an occlusion in the anterior circulation, and essentially taking those patients for endovascular treatment. And also endovascular treatment itself was evolving. So it started making more emphasis on the mechanical part, like stent retrievers, and less emphasis on the pharmacological part, like the intra-arterial thrombolysis injection. And after 6 hours, there was emphasis on using the plain CT scan and perhaps using collateral circulation on the CT angiogram as a surrogate for viability and taking those patients for endovascular treatment. By 2018, there was a more systematic way of selecting patients who presented after 6 hours. So essentially determining the infarct core and perfusion using quantitative automated assessment. And pharmacological approach really started diminishing. So really people started focusing on the mechanical part and not so much on the intra-arterial thrombolysis part. And then by 2022, people started questioning whether there was even a role for intravenous thrombolysis. Maybe if mechanical thrombectomy provides the recanalization, why even give intravenous thrombolysis, increase the expense, increase the risk prior to the procedure. But the problem here is that all this data comes from patients who had an occlusion of the middle cerebral artery or the internal carotid artery. But occlusions occur in other locations as well. So if you look at a cohort of patients coming with acute ischemic stroke, you can see that there can be occlusions in the other regions, including the basilar artery. So somewhere around 10–11% of the patients have an occlusion of the basilar artery. So what do you do when you have no data on basilar artery occlusion? So we really did not know at that time what was the relative benefit or even the best modality for endovascular treatment for occlusions located in locations other than the intracranial internal carotid artery or the proximal middle cerebral artery. It appeared unlikely that treatment centers would not offer endovascular treatment of patients who have occlusion in other locations, particularly basilar artery occlusion. But there probably is more likely to be a greater emphasis on angioplasty and stent placement in basilar artery or the extracranial internal carotid artery. Now, one option is that just assume that everything that we learned from treating occlusions in the internal carotid artery or the middle cerebral artery can be extrapolated to basilar artery occlusion. Now, there are certain things that one has to consider. While angiographically it's an occlusion, but there are more issues involved here. One is that the occlusions in the internal carotid artery, the intracranial internal carotid artery, and the middle cerebral artery are usually a normal artery with a superimposed thrombus. While the occlusion in the basilar artery are somewhat different, there's a much higher burden of an intracranial atherosclerotic plaque with a superimposed thrombus. So the occlusion, the nature of the occlusion is somewhat different when it comes down to the anterior circulation and the posterior circulation, with a much larger burden of atherosclerotic lesion underlying the occlusion. Also, the risk of post-thrombolytic intracerebral hemorrhage is different. Somehow the risk is lower in posterior circulation or basilar artery occlusion as compared to the anterior circulation. But if you do get a post-thrombolytic intracerebral hemorrhage, it is more likely to be fatal when actually seen in the basilar artery occlusion as compared to the anterior circulation occlusion. Now, the other problem is that, as we looked earlier, that in the anterior circulation, you have cerebral or CT perfusion. You have a quantitative automated assessment to determine the tissue at risk. You don't have anything like this in the basilar artery occlusion. You have a well-established interpretation or semi-quantitative interpretation for early ischemic changes using the CT scan, the aspect score in the anterior circulation, validated numerous times. While in the posterior circulation, you have the posterior circulation aspect score, but it's clearly less validated, and there is less knowledge about the cutoff, the threshold, where to select the patients. And then the randomized clinical trials, at least up to 2022, were very convincing about anterior circulation, but not so convincing about basilar artery occlusion. Now, what do I mean by that? So the first randomized clinical trial, the basilar artery occlusion endovascular intervention versus standard medical treatment, the BEST trial, took patients who had basilar artery occlusion within 8 hours and randomized them to endovascular treatment, mechanical thrombectomy, or best medical treatment. And a portion of those patients actually received intravenous thrombolysis because they were candidates for intravenous thrombolysis. Essentially, 66 patients were randomized to endovascular treatment and 65 patients to best medical treatment. So the primary endpoint was the modified Rankin scale 0 to 3 at 90 days. Now, it's actually important to know that for basilar artery occlusion, the modified Rankin scale 0 to 3 is used as a favorable outcome, as opposed to 0 to 2 that is seen in the anterior circulation, because the severity of stroke is higher in basilar artery occlusion, and it's more reasonable, even a modified Rankin scale 0 to 3, which would include mild or moderate disability, is considered a favorable outcome. So the risks, 42% of the patient achieve favorable outcome in endovascular group, 32% in the best medical treatment group. Obviously, looking at the number of patients, you can see it's highly underpowered, and it did not make statistical significance. But one of the main reasons why this trial did not continue recruitment was the crossovers. So patients who were actually randomized to endovascular treatment, 22 patients who were randomized to best medical treatment, 22% of those patients crossed over to get mechanical thrombectomy because the physicians or the patients or the relatives did not feel it was in best interest to get best medical treatment. So it was a true violation of the equipoise, because there is already a preconceived notion that mechanical thrombectomy is superior to best medical treatment, even when you have been randomized to best medical treatment. So it truly confounded the results of the trial. And if you actually analyze the data as per protocol analysis, so patients who actually were randomized got the treatment they were assigned to, there is a clear benefit for endovascular treatment. 44% achieving favorable outcome as compared to 25%. But since intent to treatment remains the gold standard for comparison, the final results of the trial were that there was no difference between mechanical thrombectomy as compared to best medical treatment. Now, there was actually another trial done in Europe, the Basilar Artery International Cooperation Study, the BASIC trial, that was actually looking at patients within 6 hours of symptom onset, so patients who had angiographically demonstrated basilar artery occlusion within 6 hours of symptom onset, randomized. And obviously, as you can see that these patients are being randomized in the earlier time window, a large proportion of these patients actually got intravenous thrombolysis. So 154 patients randomized to mechanical thrombectomy, 146 randomized to best medical treatment, heavily dominated with intravenous thrombolysis. Now, if you look at the modified Rankin scale 0 to 3, 44% compared to 38%, a non-significant difference with endovascular treatment. So really, you don't see a benefit of endovascular treatment, or not a significant benefit of endovascular treatment in this particular study. And this is despite the crossover being minimized. So really, the crossover was 5% or less. And yet you don't really see a benefit of endovascular treatment, or a convincing benefit of endovascular treatment. Now, essentially, these trials also allowed patients who had initial NIH score of 10 or less than 10. And if you divide these patients and analyze them separately, so let's analyze the patients who had an initial NIH score less than 10 and look at the benefit of endovascular treatment, and patients who had an NIH score greater than 10 and look at the benefit of endovascular treatment. And you can see there's a clear discrepancy. So in the patients who have mild deficits, you don't really see a benefit of endovascular treatment, because it appears that those patients appear to do well with best medical treatment, heavily dominated by intravenous thrombolysis. If you look at patients 10 or greater, there seems to be a benefit, a significant benefit of endovascular treatment. So this trial, even though if you look at the intent to treat, the primary analysis did not show a significant benefit of endovascular treatment, but it taught an important lesson that you have to take patients with moderate to severe strokes to really demonstrate the benefit of endovascular treatment when it comes down to patients with basilar artery occlusion. So now I think, taking all these lessons together, there were 2 randomized clinical trials that were designed in the last 5 years, and both of them were actually published recently. You have the ATTENTION trial, the trial of endovascular treatment of acute basilar artery occlusion, and you have the trial of thrombectomy 6 to 24 hours after stroke due to basilar artery occlusion. So one is called the ATTENTION trial, the other one is actually called the BOAC trial, the basilar artery occlusion Chinese endovascular trial. So these 2 trials were designed to take patients who had a basilar artery occlusion. So an angiographically demonstrated basilar artery occlusion. The occlusion could be demonstrated by a CT angiogram or an MR angiogram or even a conventional angiogram. The attention trial was actually looking at patients within 12 hours of symptom onset, while the basilar artery occlusion Chinese endovascular trial was looking at patients between 6 and 24 hours after symptom onset. So somewhat different time windows, but the concept is the same, that these patients are being randomized to endovascular treatment or best medical treatment. Now, both of these trials made an effort to not repeat the mistake of basic trial and only include patients who have moderate to severe neurological deficits. So NIS stroke scale of 10 or greater. So that was the minimum entry criteria for both of these trials. And also trying to make an emphasis to exclude patients who have early ischemic change. So we don't really have an automated quantitative way of making the determination in the basilar artery occlusion. You just have an equivalent of the posterior or a posterior circulation aspect score. So here you actually have the attention trial actually said that if the patient was younger, the patient had to have an aspect score of 6 or greater. So not a lot of early ischemic changes. If the patient was older, then even a higher threshold, so only taking patients in whom you had the minimal acute ischemic stroke changes. And the basilar artery occlusion Chinese endovascular trial used a cutoff of 6 or greater, and also used a secondary cutoff, which is the Pons midband index. So it actually looks at either an MRI or a CT scan and looks at the amount of tissue that's involved with early ischemic changes, and using a threshold of less than 2. And the posterior circulation aspect score essentially looks at different regions, but regions that actually supply the posterior are supplied by the posterior circulation. So that means the thalamus, the occipital lobe, the pons, the midbrain, and essentially quantifies the ischemic changes in this particular regions and gives it the score. So in the attention trial, here you can see the distribution of where the occlusions were. So only a small proportion had intracranial vertebral artery occlusion, and then almost an equal proportion of distal basilar artery occlusion, mid basilar artery occlusion, and proximal basilar artery occlusions. So here you can see the results. Patients randomized, 228 patients randomized to mechanical thrombectomy, 114 patients randomized to best medical treatment. And again, a small fraction of them actually received intravenous thrombolysis. Now, this time, if you look at the modified Rankin scale 0 to 3 at 90 days, a twofold higher chance of achieving that if you were randomized to mechanical thrombectomy, 46%, as compared to 23% with best medical treatment. So in this 2-to-1 randomization scheme, an overwhelming benefit of endovascular treatment as compared to best medical treatment. So this trial, clearly using the enhanced criteria for patient selection, was able to demonstrate a convincing way the benefit of endovascular treatment over best medical treatment. Now, a little bit more description on mechanical thrombectomy. So there was no specific guidance for mechanical thrombectomy, so people can do mechanical thrombectomy the way they actually thought appropriate. So the interventional neurologist, neuroradiologist, neurosurgeon can do the thrombectomy as they saw fit. So general anesthesia was used in 56% of the patients. Angioplasty and stent placement was used in 40% of the patients. So very high rate of angioplasty and stent placement. And because it was thought a large proportion of them had intracranial atherosclerotic disease. And tirofiban, which is a glycoprotein 2B3 inhibitor, was used in 40% of the patients. So the endovascular treatment is somewhat different than the endovascular treatment that we have used in the anterior circulation. So even though we're using the term mechanical thrombectomy, it needs to be clear that there is a certain amount of differences in what mechanical thrombectomy in this trial meant as compared to all the other trials in the anterior circulation. And if you look at modified Rankin scale 0 to 2, so if you use that as your primary endpoint, again, there is a significant benefit, a threefold higher chance of achieving modified Rankin scale 0 to 2, 33% as compared to 11%. So almost an overwhelming benefit of mechanical thrombectomy in the tension trial. And if you look at the secondary endpoints, so recanalization through a non-invasive test at 24 to 72 hours, 91% versus 38%. So there is some recanalization in the medical management group as well. The NIS stroke scale actually looking better at 24 hours, but looks even better at day 7 of discharge. So clearly you're seeing early neurological improvement in the group that got endovascular treatment. And if you look at hemorrhages, as expected, the intracranial hemorrhages were higher in the endovascular treatment group. But the symptomatic hemorrhages were actually pretty low, only 5% as compared to none in the medical treatment group. And this trial actually had something very unique. It was actually showing a mortality benefit. So all the other trials that we've seen with mechanical thrombectomy in the anterior circulation, the benefit is in terms of reducing disability, but not necessarily reducing death. In this trial, you can actually see a significant benefit in survival or reduction in mortality. So 37% of the patients died with mechanical thrombectomy, while 55% in the best medical treatment group. And the benefit was seen all across the spectrum. So if you do subgroup analysis, you can see the benefit of endovascular treatment, all the subgroup analyzed, whether the patient got intravenous thrombolysis or not, but it's somewhat of a lesser benefit when patients get intravenous thrombolysis. So it's kind of saying that intravenous thrombolysis also is pretty effective in patient with basilar artery occlusion. More importantly, if there is a benefit according to time, so maybe there is a time window. So if you divide the patient in less than 6 hours and more than 6 hours, it appears the benefit is the same. So patients, even who present after 6 hours, between 6 and 12 hours, clearly seem to benefit from endovascular treatment. And the benefit is also seen regardless of the severity of stroke and also regardless of the age dichotomy. So really the benefit is sustained in all patient subgroups that were actually analyzed as a pre-specified analysis in the tension trial. Now, what about the BOAC trial? So in the BOAC trial, you can see that more patients actually had proximal basilar artery occlusion than the mid-basilar artery occlusion or the distal basilar artery occlusion. So there was a little bit more preponderance of proximal basilar artery occlusion in this particular trial. And since the window was 6 to 24 hours, a much smaller fraction of patients actually got intravenous thrombolysis. So 110 patients randomized to mechanical thrombectomy, 107 to best medical treatment. And again, the trial showing a significant benefit. The modified Rankin scale 0 to 3 at 90 days, 46% in the mechanical thrombectomy group, 24% in the best medical treatment group. So again, an overwhelming benefit of mechanical thrombectomy in basilar artery occlusion between 6 and 24 hours after symptom onset. So this trial also convincingly showing the benefit of mechanical thrombectomy over best medical treatment for basilar artery occlusion presenting between 6 and 24 hours. But again, mechanical thrombectomy concept is somewhat different than mechanical thrombectomy in the anterior circulation because 55% of the patients got angioplasty and stent placement. 54% of the patients received a glycoprotein 2B3 inhibitor. And general anesthesia was used in 65% of the patients. So yes, mechanical thrombectomy is advantageous, but the face of mechanical thrombectomy is somewhat different than what our understanding of mechanical thrombectomy is based on the experience in the anterior circulation. And again, if you do a modified Rankin scale 0 to 2, you still see the benefit of endovascular treatment, 39% versus 14% mechanical thrombectomy compared to best medical treatment. And again, if you look at recanalization at 24 hours, a significant benefit, 92% versus 19%. If you look at dramatic neurological improvement, which means the neurological deficit improved by 8 points or greater, a significantly higher chance in mechanical thrombectomy as compared to best medical management. So like the tension trial, the BOAC trial showing the same, you can start seeing the benefit of endovascular treatment very early on after the intervention. If you look at intracranial hemorrhages, a slightly higher chance of intracerebral hemorrhages. So 9% of the patients got symptomatic intracranial hemorrhage with mechanical thrombectomy as compared to 2% in the best medical treatment group. And somewhat higher chance maybe because the risk or patients were being treated in the later time window. So perhaps patients being treated in the later time window may have a higher risk of intracerebral hemorrhage. Again, a somewhat of a mortality benefit as well. 31% of the patients died within 90 days as compared to 42% in the best medical treatment. And if you actually look at the subgroup analysis, really no difference when it comes down to age. So really, it's interesting that even patients who are more than 70 years of age appear to benefit from endovascular treatment when they have basilar artery occlusion and are being treated between 6 and 24 hours after symptom onset. Not a real difference even when it comes down to NIH stroke scale. So even patients with severe neurological deficit appear to benefit from endovascular treatment. And also, if you look at the time window, patients who actually are in the 6 to 12 hour time frame and compared to 12 to 24 hour time frame, the benefit appears to be the same. So the benefit of endovascular treatment really is persisting even in the 12 to 24 hour time window when you do a subgroup analysis of the BOAC trial. So I think that all of this combined together is saying that the time window may be up to 24 hours for basilar artery occlusion patients when we are using mechanical thrombectomy. So let's just pool it all together. So all 4 trials pooled together in the form of a meta-analysis. So 988 patients have been randomized, 4 different clinical trials. And if you do a meta-analytic approach, and you look at the primary endpoint of a modified Rankin scale 0 to 3, so again, 0 is no symptom, 1 is no significant disability, 2 is slight disability, and 3 is moderate disability. A 2-fold higher odds of achieving that with mechanical thrombectomy as compared to best medical treatment. So the odds ratio is 1.99, a confidence interval between 1.3 to 3.2. And a significant survival benefit or a significant reduction in mortality as well. So again, what we are seeing is a mortality benefit in basilar artery occlusion, something we haven't seen in the anterior circulation. The odds of dying within 90 days, 0.64, is significantly lower odds of dying at 90 days with mechanical thrombectomy as compared to best medical treatment in patients with basilar artery occlusion. So I think that there is overwhelming evidence of the benefit of mechanical thrombectomy with a particular understanding about what mechanical thrombectomy means in basilar artery occlusion as compared to best medical treatment. Now, there's always this concept that whether the results in clinical trial can be extrapolated to clinical practice or routine practice. So the clinical trials, particularly the basic trial and the attention trial, also had a registry that precluded the clinical trial. So you had data from clinical practice, and then you have data from the clinical trial itself. So if you look at the proportion of patients with modified Rankin scale 0 to 3 in the registry that's highlighted in the yellow bar, 25% achieved that with endovascular treatment, while 45% achieved it in the clinical trial. In the attention trial, 40% in the registry and 45% in the clinical trial. And then in the basilar trial, which is somewhat close to the best trial or the basilar registry. So somewhere around 30% of the patients had a modified Rankin scale 0 to 3 in clinical practice, while in the best trial, around 44% achieved that mark. So yeah, I think we have to understand that when mechanical thrombectomy will be applied in routine practice, the magnitude of benefit may not be that much as compared to what is seen in clinical trials. That is actually pretty common. There's always that discrepancy when you take results applied in or found in clinical trials and apply it to clinical practice, because patients with more severe deficits and perhaps more adverse baseline characteristics get included in routine practice. So where does it leave us with basilar artery occlusion? So we saw this protocol for predominantly an anterior artery occlusion. With basilar artery occlusion, now in 2023, this is what the protocol looks like. Patients who get or are candidates for intravenous thrombolysis should get intravenous thrombolysis. I think that the basic trial showed that intravenous thrombolysis can be pretty effective. And patients who have an angiographic demonstrated occlusion should be considered for endovascular treatment. And after 4.5 hours, all the way to 24 hours, patients who have a basilar artery occlusion do not have extensive ischemic changes on the plain CT scan. And again, the posterior circulation aspect score, perhaps 6 or greater being the appropriate cutoff, should be considered for endovascular treatment. But I think we should be a little bit aware that endovascular treatment may not necessarily mean the same in basilar artery occlusion as compared to what was seen in the internal carotid artery and the middle cerebral artery occlusion, because there seems to be a greater role for angioplasty and stent placement, and perhaps a greater role for the glycoprotein 2b3 inhibitors. And also some emphasis on selecting patients with an NIH stroke scale of 10 or greater. So perhaps there is a role for endovascular treatment, but not in patients with mild neurological deficits, but those patients who have moderate to severe neurological deficits in the presence of a basilar artery occlusion. Now, where do we go from here? Well, I think that there is still a question about the role of intravenous thrombolysis in basilar artery occlusion. There have been 6 clinical trials looking at the role of intravenous thrombolysis prior to an anterior circulation occlusion and thrombectomy. And now with intravenous tenecteplase instead of intravenous alteplase, so the question becomes, is there a role of intravenous tenecteplase prior to mechanical thrombectomy in basilar artery occlusion? And the second set of attention trials will actually be looking at that particular question. I think that there is a question, what is the best strategy for mechanical thrombectomy? Is aspiration the best strategy, or is stent retriever the best strategy? And initial data may suggest that aspiration may be superior to stent retriever for basilar artery occlusions. What is the role of intra-arterial thrombolysis during mechanical thrombectomy? Is there any role for intra-arterial thrombolysis? What is the role of stent placement and intravenous or intra-arterial glycoprotein platelet 2b3 inhibitors? And most important question that everybody is asking, that out of the 4 trials that have been done, 4 randomized clinical trials, 3 have been done in China. Can we take the results of a Chinese trial and apply it to North American and European population? Because if you look at the role of angioplasty and stent placement in basilar artery occlusion, in the basic trial, which is a more European population, 26% of the patients received an angioplasty or required a stent, while 40 to 55% received it in the BOAC or the attention trial. So it seems like the intracranial atherosclerotic burden is larger in the Chinese trials as compared to the North American European trials, and whether the results that are derived from Chinese trials can be extrapolated to the North American or the European population. Now, science is also evolving. Like this particular patient, you can see there is a basilar artery occlusion. The top of the basilar artery is actually occluded with a thrombus. And after actually aspiration, you can see this complete angiographic recanalization. Now, in today's world, you can actually do perfusion imaging with the angiographic units. So here, actually, you can see a perfusion image immediately after recanalization. Then you actually inject intra-arterial tenecteplase, so 10 milligrams of intra-arterial and tenecteplase, and then you repeat the perfusion imaging. And you can see there's actually improvement in tissue perfusion after giving intra-arterial thrombolysis. So despite the fact that even in the first image, angiographic recanalization had been achieved with primary mechanical thrombectomy or aspiration, there were still perfusion deficits, and that actually improved after giving intra-arterial thrombolysis. So I think that where we're going is also an evolution. We are starting to expand our focus. When we have been talking about medium-sized arterial occlusion, now we are also talking that perhaps there is a burden of occlusion in the small arteries and small arterioles, and even at the level of the capillaries that have been ignored in the past. And for us to gain the maximum benefit of endovascular treatment, we have to focus on these elements in the ischemic tissue. So even if we get medium-sized arterial occlusion recanalized with the stent retriever or the suction catheter, the small arterial and arterial occlusion and the capillary occlusion is not going to be influenced by these devices. And we need a better strategy to achieve recanalization of tissue perfusion at that particular level in the ischemic tissue. And only then we can have the optimal perfusion at the tissue level. And whether intra-arterial thrombolysis and adjunct to mechanical thrombectomy can achieve that purpose is something that needs to be seen in future clinical trials. But again, when we're using more pharmacological approaches, we also have to be aware that there may be a greater burden of intracranial hemorrhages as well. So the risk-benefit ratio has to be clearly evaluated in the setting of carefully planned randomized clinical trials. So I'm actually going to conclude here with the following statement. I think that recent clinical trials have demonstrated significant benefit in mechanical thrombectomy in acute ischemic stroke patients with basilar artery occlusion, but using unique patient selection criteria and unique treatment paradigms. So I think there is some emphasis on the patient selection criteria and some emphasis on the treatment paradigms that define mechanical thrombectomy in this clinical trial. Several aspects of mechanical thrombectomy and basal artery occlusion require further study. And perhaps the biggest question that faces us is, as the American Heart Association, American Stroke Association Guidelines Committee is struggling with how to incorporate this in the guidelines, is whether results derived from Chinese studies can be extrapolated to the North American European population, or a separate clinical trial will be required before we can incorporate these results into our practice in North America. I'm going to conclude here. So thank you very much for being here and listening to the talk.
Thank you so much, Dr. Qureshi. I think that was an excellent presentation. So we'll have some questions. So the first question is from Dr. Hausen on the chat. So he says, hi, I'll have to jump off before the end. So maybe someone could ask Dr. Qureshi what his thoughts are related to PCA occlusion specifically as compared to other distal occlusions such as M3 versus ACA.
This is an interesting question because classically what had been believed is that posterior cerebral artery occlusions perhaps are too distal and not necessarily amenable to thrombectomy. But I think that recently, you have aspiration catheter that actually have a smaller caliper. In addition, you have retrieval devices that have a smaller diameter. So the posterior cerebral artery occlusion is potentially amenable to thrombectomy. And I think that what really determines is the severity of deficits, because some of the posterior cerebral artery occlusions, because of collaterals, may actually spare a lot of the visual cortex and may not involve the motor system at all. But on the other hand, you may have proximal posterior cerebral artery occlusion, but not only you have the visual cortex that impaired, you also have the whole motor system, because some of the thalamus-striate arteries actually supply the internal capsule. So I think that you have to make that decision on case-to-case basis. I think that the initial severity of neurological deficits perhaps is the best guide whether to perform mechanical thrombectomy or not. And I think that this is an open question. I think that mechanical thrombectomy is being provided to patients with isolated posterior cerebral artery occlusion on case-to-case basis, but I think we don't really have a consensus what patient group is most likely to benefit and what is the best treatment strategy for this patient. Now, on the other hand, if you look at the NIS stroke scale grades for visual field deficit, you don't really get a lot of points on that, but nonetheless, losing a visual field can be pretty disabling in the long-term outcome, and particularly in terms of functional status. So that also has to be put in the equation, whether to actually perform mechanical thrombectomy or not.
Excellent, sir. Thank you. So on a similar note, what about vertebral artery occlusions? So that's the other thing. So we have patients with distal vertebral occlusions and with debilitating deficits. So what are your thoughts on that?
So in a typical scenario, in the best case scenario, you have two symmetrical vertebral arteries that fill the basilar artery. So essentially, if you have a isolated vertebral artery occlusion, the only thing at risk would be the posterior inferior cerebellar artery. Unfortunately, in more than half of the patient, that is not the case. Usually you have a dominant vertebral artery and a non-dominant vertebral artery, which could even be hypoplastic with no contribution to the basilar artery. So if your dominant vertebral artery is actually occluded, the whole basilar artery is actually at risk. So in that scenario, essentially it goes down to what the attention trial did, that you have to include them in the thrombectomy category. So you actually have to offer them thrombectomy because the whole basilar artery is at risk. In the presence of a isolated vertebral artery where there is a patent normal vertebral artery from the contralateral side that's supplying the basilar artery, it becomes a little bit less convincing. So I think that, because if you look at the long-term outcome of posterior inferior cerebellar artery strokes, 92% actually are independent at 6 months. So I think that, perhaps if you have a patent vertebral artery and a patent basilar artery, and you have a unilateral vertebral artery, perhaps the case for a mechanical thrombectomy is not so convincing, as it is more convincing if you have a hypoplastic or aplastic vertebral artery on the other side, and the dominant vertebral artery is compromised.
Thank you. Any other questions from the group?
Hey, Adnan, Mike Frankel, how are you?
Hey, Dr. Frankel, how are you?
Great to see you. Listen, I really appreciate you doing this. Do you think that there's enough clinical equipoise now to randomize patients, say a young patient with a basilar artery occlusion that has a perfectly normal looking CT scan? Do you think that would work?
So this is a very good question, and I think that one of the biggest impediments to randomized clinical trials in North America has been that there was a notion that patient with basilar artery, 80% of them actually have severe disability or die. So people felt that there was no equipoise, essentially just offering the mechanical thrombectomy was the best option. But in the last, I think 20 years, there's been more and more data that perhaps a patient with basilar artery occlusion, not all of them have such level of disability. And even intravenous thrombolysis is relatively effective in this patient population. So now the question becomes is, now you have the attention trial and the BOAC trial, both of them overwhelming benefit of endovascular treatment, and whether there is a equipoise in practice to do another clinical trial in North America or Europe, or one should just assume the results from the Chinese trials and just offer endovascular treatment. I think the argument not to do another clinical trial will be the magnitude of benefit. Meaning you have a twofold higher chance of achieving favorable outcome in mechanical thrombectomy, and whether one would think that this is just such an overwhelming benefit that it's just not, there's not enough equipoise. Nobody's convinced to actually randomize these patients anymore. The other opinion would be that a lot of this occlusion in the Chinese trials were really intracranial atherosclerosis, which is more amenable to angioplasty. More benefit could be seen with the glycoprotein 2b3 inhibitor, and that may not necessarily be the case in the North American, European population. And I think that that's a question for all of you, that do you think that there is an equipoise? Should there be a North American trial, or there's just nobody's going to be interested in randomizing anymore, and everybody will be offered endovascular treatment.
I think it would be very hard to have a trial that, I think there'd be too many people that would be treated outside the trial and it would hurt the randomization. So I think that would be my concern. Depends on whether there's a subset that we're going after that, that maybe is a little more challenging, particularly on the intracranial stenosis group. That might be there might be more equipoise there because of its challenges. But anyway, thank you so much for this, and miss seeing you on a regular basis. Obviously, you're far away from us, and I hope to see you down in Texas.
Yes, it's always great to be part of the group.
Yeah, you're always part of our group.
Same here.
Yeah.
I'm proud to be part of your group.
So any other questions? Okay, sir. So last one before we end. So you mentioned about intervention 2. Is that going to include the North American population too, or is it all again Asian population?
So the Tension 2 is going to be a Chinese trial. And right now the design is actually moving forward. And the Tension 2 is looking at the use of intravenous tenecteplase versus a no treatment before thrombectomy. So everybody will get thrombectomy.
Mm-hmm.
And the question that is being asked is that whether intravenous thrombolysis really adds any additional benefit within less than 4.5 hours of symptom onset. And between 4.5 hours to 24 hours, is there an additional benefit of adding an intravenous thrombolytic prior to thrombectomy?
Sure. Excellent. So we have one of our senior residents who posted a question. There was a reduction in mortality as shown in the trial. Are there any predictors of those who survive with disabling deficits?
So that's an interesting question that, and it's always been a question about every stroke trial, particularly in subarachnoid habitat interstitial hemorrhage, where you have a reduction in mortality, but whoever is surviving may not necessarily be making it a favorable outcome. May actually simply you took mortality and turned it into this severe disability. So we don't really have the subgroup analysis at this point to make that determination and whether the shift actually occurred. So basically people who survived, when you look at the distribution of the modified Rankin scale, it appears that the shift actually, some of them did make it all the way into the modified Rankin scale 0 to 3. So some of the survivors actually didn't turn into just severe disability, but made it all the way into a more favorable outcome. But I think that that's just a visual interpretation of the distribution of modified Rankin scale between those who got mechanical thrombectomy as those got best medical treatment. And I think that's always been a very important question of basilar artery occlusion, that whether you may actually make the patient survive, but then if you're really turning the survival into some form of a severe disability, which may not be a desired outcome from the patient or the family perspective. But at least on the visual interpretation, seemed like a lot of those patients who survived actually made it all the way to a favorable outcome.
So we have another question. Any future RCT trials that will see if intra-arterial thrombolytics will add benefit to microcirculation after thrombectomy?
So yes, so there are trials that are being planned right now. And the concept is that, yes, if you look at them, there is a concept called futile recanalization that has been recognized since the late 2000. As our ability to open occluded vessel improved, we started realizing that almost half of the patients that actually have angiographic recanalization do not have clinical improvement and have disability or die as a consequence of their stroke. So, well, one is that, maybe it's just too late to open the blood vessel, but I think that there is an important component there that even what you see as a medium-sized artery recanalization, the tissue perfusion has not been restored. And now there is more information through perfusion imaging, MR perfusion imaging, that the perfusion deficits are still there despite angiographic recanalization. And obviously, if the perfusion deficits, because the small arteries, arterioles, or capillary occlusions are still there, the tissue will still suffer ischemic damage. So now I think that, we are realizing that, look, we've become pretty effective in opening medium-sized arteries, but to really have the clinical benefit match the angiographic recanalization, we have to do something about distal perfusion. So there are trials that are being planned right now about intra-arterial thrombolysis as an adjunct to mechanical thrombectomy. So essentially, before intra-arterial thrombolysis was initially the go-to endovascular treatment, and then with mechanical thrombectomy, it started losing its role, and now it's actually starting to make a comeback. And the tension group, our group, are all designing clinical trials that will be looking at intra-arterial thrombolysis as adjunct to mechanical thrombectomy.
Awesome. And Dr. Rangaraju has raised his hand. So
Thanks, Dr. Qureshi. It's really nice talk. This is Shrikant. So one comment or question is, you raised the important question, the point that can we assume that the benefit of thrombectomy in a Chinese population with a lot more underlying ICAD can be adapted in, say, in the West? And my counter argument is more related to the anterior circulation, where I believe in China, if you look at some of the nationwide real world registries, about 30% of patients who have anterior circulation thrombectomy have underlying ICAD in the parent lesion, and they undergo thrombectomy. And in those patients, the association between successful reperfusion and good outcome, it has the same magnitude of effect as seen in say the United States or Canada. So I guess the point I'm trying to make is that perhaps are we overthinking this, the issue that the underlying ICAD could really impact the effect of thrombectomy? And therefore, I was sort of I agree with Dr. Frankel as well that argument that I just that I put forward may also explain why there could be a lack of equipoise if one were to undertake a trial of this nature in the United States.
Yeah, you're absolutely right there that the difference in recanalization or the recanalization achieved with the standard thrombectomy devices and the ones that are achieved with angioplasty and stent placement, there is not a real difference in the outcomes. So if you use that recanalization by any means possible will give you the same result, in which case you are right that the results that were seen in the Chinese trial should be applicable to the US trial. In the US setting, there is a decrement in benefit with the stent placement, and not because the stent is less effective, it's because it's used as the last resort. So essentially, right now, people will try everything, and only then, once they have failed to achieve recanalization, which could be 1 hour, maybe 90 minutes into the procedure, then they will consider the stent placement. So you've actually biased the population. If you had used the stent placement early on, you would have seen a greater benefit. And I think that there is definitely a role for stent placement. And I think that there is the only challenge with stent placement is that a lot of the patients receive intravenous thrombolysis prior to coming to thrombectomy. And then once you put a stent in there, you're almost condemned to use some kind of antiplatelet agents, and preferably intravenous glycoprotein 2b3 inhibitors, because otherwise you will see stent occlusion. So it actually, the risk of bleeding is somewhat undetermined, that whether when you're loading the patient up already received intravenous thrombolysis, now you started an intravenous glycoprotein 2b3 inhibitor, whether the risk of bleeding is actually higher in this setting or not. And I think that there are certain trials that are going on, like the Clear 2, and you have the most, so far, at least on the safety side, seem like the combination of thrombolytics and glycoprotein 2b3 inhibitors is relatively safe, but we also have to understand that the dose of thrombolytics have been less in those trials. So there's a lower dose of thrombolytics that is being used in those trials.
awesome, sir. So we are on time. I are at 8:30, but we have a couple more questions. Do you think you have time to? So if yes, yeah. So one is by Dr. Gulati. Do you think IA thrombolytics would also be beneficial in anterior circulation?
The answer is there's definitely that potential, because the microcirculation compromise, like the image I showed, is not just limited to the anterior circulation, it's also in the posterior circulation, because the phenomena is the same. So I think that yes, the answer is yes, the intra-arterial thrombolysis may actually be beneficial in the posterior circulation as well. And if you look at the CHOICE trial, they had included patient with basal artery occlusion. So again, a very small fraction, but the CHOICE trial actually showing that at least the modified Rankin scale 0 to 1 was higher when patients got intra-arterial thrombolysis despite near complete or complete recanalization with mechanical thrombectomy as compared to intra-arterial placebo.
And the last one would be, can you comment about your approach to selecting anesthesia choice in basilar occlusion? This is from our one of our vascular neurologist, Dr. Nahab.
So, this debate has gone on for a long time, that what is the best anesthesia for mechanical thrombectomy. And the results are comparable as long as certain assumptions for general anesthesia are met. One is avoidance of hypotension during induction of general anesthesia. Second is avoidance of hypocapnia during intubation, because it seems like hypocapnia in itself worsens ischemic injury, and obviously hypotension worsens ischemic injury. So as long as these parameters are respected, seem like the results are the same with general anesthesia and local anesthesia. If these parameters are not respected, then you do actually have a price to pay for general anesthesia. Now, each center differs, so we don't really know, apart from randomized clinical trials where parameters are optimized, the results will be the same. And again, there is no trial in the posterior circulation. I know that the best trial investigators are actually doing an analysis comparing general and local anesthesia. So when that comes out, we may get some sense. Again, that's not a randomized comparison. So now you have a disparity in opinions and variation in practice between centers. In our center, everything has become general anesthesia just to maintain a certain sense of consistency, with the understanding that perhaps some patients could have been treated with in awake state or conscious sedation. But I completely understand that there's variation in different settings. I think that till a randomized clinical trial comes in, I think people will have to just use their judgment on case-to-case basis.
Sounds good. Sir. Thank you so much. And again, thank you. This was an excellent talk, great discussions. Thank you so much again for giving this talk to us.
Thank you so much, Danesh. Thank you for organizing it. Great to see all of my great mentors on the screen today. Bye now.